Good evening, everybody. Those who are on the Facebook page of ASI, delegates, members, postgraduate students, a warm welcome to all of you to the 14th episode of NSCP 2022. Today, we are going to have a discussion on CT scan interpretation in various situations. Once again, let me take this opportunity to warmly welcome those who have joined from SAARC countries, South Africa, sister organizations like gynecologists, otolaryngologists, orthopedic surgeons, etc. May I have Dr. Pradap Burade, Honorary Secretary, to extend a formal welcome to all of you. Dr. Burade.
Yeah, good evening, sir. Thank you very much. Esteemed faculties who have joined for today's NSAP episode 14, which the ASI is conducting religiously from February 2022. This is the 14th episode. All the postgraduate students, consultants who have joined for today's program, our President, Dr. G. Siddesh, Vice President, Dr. Sanjay Jain, Director Academic Council, Dr. Santosh John Abraham, sir, Treasurer ASI, Dr. Bhawarlal Yadav, and all the esteemed members who have joined for today's program. CT scan, which was treated as an fancy investigation in our PG days, I remember, is now a mandatory and a primary investigation for most of us surgeons. I must confess that we can treat it as our surgeon's stethoscope nowadays. Not only it is useful in a diagnostic evaluation, but at the same time, we are doing the interventional procedures regularly by using our CT scan. And to elaborate on the same issue, we have a panel of experts, Pan-India, moderated by Dr. Puneet Dhar from AIIMS Rishikesh. And the panelists are Dr. Sudeep Shah from Mumbai, Dr. Madhur Uniyal from Rishikesh, Dr. Parthasarathi Ghosh from West Bengal, Dr. Venu Madhav Thumma from Hyderabad, Dr. Sanjeev Haribhakti from Ahmedabad, and Dr. Rajiv Gupta from Chandigarh. So once again, I welcome you all for this NSAP 14th episode, which the ASI is conducting regularly. Over to you, Santosh sir.
Welcome once again to all the panelists and my dear good friend, Dr. Puneet, to take over the platform and conduct the proceedings. Puneet, please unmute. Yeah.
Thank you to all the ASI dignitaries. I think it's a fantastic. Santosh knows 10 years back, I never thought that the academics in ASI would take this form. I really, from the bottom of my heart, congratulate you guys for coming up with such a fantastic series of sessions. And I think the fact that these are available online also subsequently is a boon for the the busy surgeons, the young kids who cannot actually join live. And much of this discussion can even continue on the Facebook page. That's why I guess you took that conscious decision to go on to the social media rather than just YouTube. So I think I must welcome my galaxy of stellar. It's difficult to get such a huge star cast for a multi-star movie. And as Dr. Varute said, ultrasound used to be considered the surgeon's stethoscope. But now, I used to joke in my old hospital at Amrita that most of the kids, especially in private hospitals, when they come to the casualty, and I'm sure Madhur will bear me out with that, they come in and they write hemoglobin, TLC, DLC, CT scan. So with that, I think this is a very crucial session where you must know what is the background, what is the funda, what is the the reason we do it, and what could be the potential pitfalls because of that. So CT, I think all of you are aware, was the development has been not that far back. In fact, it's a coincidence that the year I joined medicine in 1979, Cormack and Hounsfield got the Nobel Prize in medicine for that year. And I think it's one of the fastest prizes given because it's only in that decade that the development really happened. But the previous history is actually interesting, where this neurologist in sort of 1959, I think, who looked at this automated series of imaging device, which is looking at frostbitten fruit and found that they were discarding fruit which had sort of dried off. And it was basically developed for the head. So it's an irony that we are not dealing with head today, but because the skull was impenetrable but for X-rays, they cracked it open using X-rays itself and converted into slices by using collimated beams. I think Sudeep is going to tell us in detail about that. And I think without further ado, we shall go ahead with. We are starting with Dr. Sudeep Shah from the Hinduja Hospital, one of the most erudite and eloquent surgeons I've ever heard. I think that my highlight was at a debate in Sao Paulo against one of the most famous surgeons, a debate on octreotide, I think, if I remember correctly, in the pancreatic fistula, pros and cons. So I thought he would be the best person to deal with the understanding the basics. I was requesting Santosh whether I could get a radiologist, but he was very sure that he wanted only surgeons. And I think I understand that it's a very important thing that the surgeons explain all these fundamentals to the students, because it's exactly the way we understood it. So without further ado, Sudeep, all yours.
Please unmute Sudeep. Dr. Sudeep.
Thank you very much for that kind introduction, Puneet. And you've already given the historical background. I'll just share my slides. I trust that it is visible. Yeah, to all.
Yes,
yeah.
Yes.
So the topic given to me is the basic interpretation of CT scan for surgeons. I have no conflict of interest. And as Puneet has said, all of us are surgeons. We are not professional radiologists. We don't want to step on their toes. But since it's such an integral tool to the management of our patients, we need to have a basic understanding of how it really works. And I'll take you through some of the basics, the pros, the cons, what can really go wrong, as a kickstart to this very exciting session that we have ahead. So we know that X-rays pass variably through tissues, and the denser the tissue is, the more resistance there will be to the passage of these photons. And these exiting rays interact with the detection device to form a projection image of these tissues. So when it's done in a single plane, you will get your plane X-ray. And this was Nobel Prize winning technology. The first Nobel Prize, Röntgen in 1901, was for this technology. But then people wondered whether you could have a cross section of the body. So therefore, the word tomography, tomos is slice and graphy is drawing. So CAT scan or the CT scan is computerized actual tomography, where you try and use these X-rays to get a cross-section picture of the body. So basically, it starts off by a beam, and it's a collimated beam, which is now in a fan-shaped manner, passes through tissue. The detectors are opposite this. This beam goes in a circular fashion. Therefore, all these rays pass at many different angles through all these tissues. And if you remember the original conventional scanners, they would do one slice at a time, and there was a thickness, and then there would be the next slice. We progressed to one single spiral. And now the modern CT machine would be a multi-slice scanner, where you would have many of these spirals going together, which will give you a very rapid and a very quick imaging. And what basically happens is that where these rays intersect, mathematically, we can calculate the actual density of the tissue by a complex formula, because if it's passing in this direction, for example, everything in this plane here would be absorbed. If it's passing in this direction, everything in this plane would be absorbed. And using Fourier transformation, you can get a mathematical value of the density of the tissue in each area. So where you have this two-dimensional area, the mathematical value, it would be representing a pixel, which would be the smallest area of each image. And the modern machine looks at it in 3 dimensions. So you have not just the XY plane, but you have depth, which is a voxel, which gives you a 3-dimensional construction, which is wonderful because it can be played around with, it can be rotated on the console, and we can do many wonderful things with it. Now, when you have a picture element such as a pixel, how do we actually put a number into something that we can see? If it was just a patchwork of numbers, it would have no meaning for us as human beings. And we'd love to see a realistic picture. So what actually happens is that each one of these numbers is given a corresponding color, a black and white representation on a grayscale. Now, for uniformity for each and every CT machine across the world, the Hounsfield unit of 0 is used for the absorption of X-rays through tissue containing pure water. So water will give you an absorption of a Hounsfield unit 0 by convention. Air will be minus 1000, and the upper limit would then go up. Now, once you have this range, you would therefore be able to give a grayscale to represent what you need to see within this range. And just give you an example here. So this is actually a screenshot of my console. And this is a patient with a liver tumor, which you can see here. And we're looking at the liver, we're looking at the lung, you have the heart here, and you have the vertebra here. If you look at these, the numbers on this, so there is a level WL and a window width. So the level tells you on which Hounsfield unit your grayscale is centered. So the center of the grayscale would be this level, and your width would be around this. So 350 would mean that 175 above and 175 below. So within these 350 units, your grayscale would be represented. Anything which is denser than this would be white. Anything less dense than this would be black. So obviously air, as we know, is minus 1000 density, would just be represented as completely black, as you can see in this image. And bone, which is very thick, would look absolutely white in this image. But because we are interested in something which is more soft tissue, and we want a higher density definition within the soft tissue, you have the maximum range within this, which gives you the contrast between this arterial enhancing lesion and the rest of the liver here. Now, using exactly the same pixels, we can change the window centering level and the window width. So this is exactly the same information. And what you've done is that we have leveled it at 300, and we have 750 above and below, giving a window width of 1500. So that 750 above brings this bone into good resolution on the grayscale. So if you want what is called the bony window, you would have this width included, and therefore you can see the finer details of this cancellous bone. You can see the osteophyte here very beautifully, but you have lost definition within the liver because it is not centered around the soft tissue, but you have a much greater width of the grayscale. So the details are lost. You can see each rib very clearly. You can see the sternum here, and the bone is beautifully seen. And similarly, if we actually have the level as minus 500, and you have the grayscale range of 1400, 700 below, 700 above, minus 500 would center on air and the lung, and suddenly you can see the lung so beautifully, so clearly. Again, the bone is out of focus because you are concentrating on the lower end of the spectrum. The liver, you can absolutely see no detail whatsoever, but you can see these bullae, you can see the septae within the lung, you can see the parenchyma, and you can see the bronchioles within. So you get this beautiful definition just with the same information by changing the windows. So that is how the radiologist will be able to concentrate on various parts of the CT image using the same information that the machine has generated in a minute in a single scan. Also using this concept of voxels, you can have coronal slices, you can have sagittal slices, and you can therefore construct the image at various different angles, and you can rotate it as much as you can rotate a set of Lego blocks and have a look at pictures from a different angle. You can also emphasize certain parts, put certain parts in fading, superimpose areas. So here you have a lovely superimposition. This is the portal vein here. This is the hepatic artery, gastroduodenal artery, superior mesenteric artery, and a wonderful impression of the arterial anatomy, almost as good as an angiogram. So nowadays, diagnostic angiograms are never done because the CT gives you such wonderful resolution. And this is all post-processing done on software once this beautiful image has been created. Measuring each and every one of these voxels also gives us an ability to calculate volume. So for example, if I want to remove this liver tumor and I need to know the volume of the residual liver which is left behind, I just have to mark it out. It will calculate by looking at the pixels within the area. You multiply it by the width of each slice, and then you can get a 3D rendition. And lo and behold, the software will tell me that yes, my functional residual volume is about 651 cc, and which is adequate for me to proceed with surgery. So all this is basically possible with just simple manipulation and using the post-processing software. What is important when we are doing a CT is the contrast that we use. So we have oral contrast, we have rectal contrast, and IV contrast. Oral contrast can either be positive with this iodine-based dye, which we use, or it can be neutral, which is water. We know that water passes very rapidly through the gut and is absorbed. So often it is mixed with mannitol. It is important to warn patients because if they come long distances, you give them mannitol, they tend to have diarrhea afterwards. So you must tell them to be careful before they actually take their train home to avoid an embarrassing accident. But it is very good for you to actually visualize the lumen of the bowel. Neutral contrast is excellent when you're looking for a small bleeder or you're looking for mucosal enhancement, because positive contrast may actually blur this boundary. So if there was a bleeder within the wall of the bowel, if you're doing a CT angiography for a GI bleed or a pseudoaneurysm, you may not appreciate it because of the positive contrast. And neutral contrast will take away these advantages. Positive contrast is excellent if you're looking at leaks, internal fistulae, visualization of diverticula, which can be filled very beautifully by the positive contrast, in so much as a barium does that. Rectal contrast is obviously useful, and you can see a wonderful demonstration here. We've just given rectal contrast to this patient, and you can see there's a patient of Crohn's disease, thickening of the wall, and you can see this thinning of contrast as it goes through the stricture in the descending colon here. So you can get a wonderful image using rectal contrast here. The phases of the scan depending on the time of your IV contrast. So without any contrast, you'd get something which is a plain scan. Then you would have the arterial, venous, and the delayed phases. The timing of the arterial phase is very important to see what is visualized. The pulmonary arterial phase is the earliest phase. So if you're looking at something like a pulmonary embolus, you would be looking at a scan 6 to 13 seconds. Now, scanners today are so quick that within a couple of seconds, they will scan your area of interest. So we can be precise in these 5-second ranges. Your early arterial phase would give you the angiographic picture. So you'd be able to see the detailed vascular anatomy, that's at 15 to 20 seconds. Your late arterial phase would give you arterial tissue enhancement, for example, a hepatocellular cancer within the liver. So that you will see at 35 to 40 seconds. And then you have the venous phase, and different organs would give you a different appearance at times. So for the pancreas protocol CT, you're looking at 40 to 50 seconds after injection. The hepatic venous phase would come in 70 to 80 seconds. If you want to look at the kidney, around 100 seconds. And a delayed phase, for example, if you had a biliary tumor or you had fibrotic tissue, which is vascular, which is enhancing, you would get a little retention in the delayed phase, which you can do at 6 to 15 minutes. And obviously, if you wanted to see dye excretion within a ureter, for example, at 10 to 15 minutes, this delayed phase would give you a wonderful IVP type picture. So all these investigations, which used to take a lot of time, a lot of injection, a lot of plain X-rays, have now completely been replaced by CT scanning. So what is the value of a plain scan? A plain scan gives you a basic idea of calcification within tissue. So on the right, as you can see, this is the contrast scan. At this patient, you can see splenic vein thrombosis, lots of collaterals, the multiple vessels around the pancreas. This could very well be mistaken for another vessel, unless you had a plain scan where you can clearly see that this is a calculus within the main pancreatic duct. So to look for calcifications within the tissue, the plain scan is excellent. And as you can see, gas is very well seen in the plain scan. If you are suspecting a perforation, all you need is a plain scan and you see gas outside the bowel lumen, you would say that there is a perforation and you needn't do anything more to establish the fact. Here is a scan demonstrating the arterial and the venous phase. The plain scan is here. As you can see, there is oral contrast, which is positive. You can see it within the stomach and the duodenum. You can see the calcification here. There's a calcified gallstone in this patient, but there is nothing in the vessels and nothing in the parenchyma. Here you can see the aorta lie put up beautifully. You're actually seeing the superior mesenteric artery here. So this would actually be the arterial phase. The vena cava is still completely empty. And here you can see that the aorta and the vena cava are both equally enhancing. So this would be the venous phase of the scan. And here you can see that the venous branches in the liver are also enhancing and filling up. So this would be the standard plain arterial and venous phase that we are used to seeing, and different information in each phase. You'll hear a lot more in the further talks. Tissue enhancement is very important and that can be easily measured. So for example, all you have to do is put a little area here. So it tells you in this area, the mean Hounsfield units that you're looking at is about 49 here, with a minimum here and a maximum here, while you just given arterial phase contrast and the mean has gone up to 84, showing that the tissue is perfectly enhancing as the normal pancreas would do. And something like necrotizing pancreatitis, here you can see that a mean of 24 will just remain the same and not really enhance when the contrast is actually administered. What are the confounders? So what do we have to be careful about when we are doing these scans? If incorrect oral contrast is used, you will mark arterial bleeders, as I've explained. If an incorrect phase has been done, you're looking for arterial enhancement instead of which you get an arteriographic phase. It might be too early, and arterially enhancing lesions such as HCCs may actually be missed. If you don't have a venous phase properly, you may miss the venous washout of these lesions. Artifacts play a big role, and knowing your patient is very helpful before actually doing the scan. This is a patient who had pseudoaneurysm of the splenic artery, embolized with coils. So really, you're not going to get anything meaningful in a CT scan of this patient. And similarly, a CT pelvis of this patient with a hip replacement, you can see it beautifully here. The section is at that point. You're really not going to see much detail within this patient. So you need to assess what the patient has before obtaining the scan and knowing that you're going to lose data and information in this group of patients. So the next question I would like to address is that it's a fantastic tool, but can it harm? We know that there's a small incidence of contrast allergy. So every suite will be equipped with enough equipment to deal with this. There would be an intubation tray, there would be steroids, you'd have adrenaline ready within the suite. It can be a fairly dramatic incident. You need to be careful of asking the patient whether they've had previous iodinated contrast and any allergies to that. Extravasation is a terrible thing. You need to check IV access and patency. Contrast nephrotoxicity is something that you need to be careful about. So all patients need to have a serum creatinine checked. In case it is borderline, hydrate the patient. N-acetylcysteine or mucomix can be given, and soda bicarb will minimize contrast toxicity. And if a patient is on dialysis, this is a dialyzable chemical, and you must arrange the hemodialysis immediately afterwards to remove the contrast and prevent toxicity. Radiation is always a worry, and it is thought that a CT of the abdomen is equivalent to 2.7 years of background radiation, and it is estimated that the risk of having a radiation-induced cancer because of CT scans is about 1 in 2,000, and you're more likely to die statistically of a fire or in a car crash after driving 40,000 miles. So it is a very, very small risk, but we need to be very, very careful when you're doing repeated scans, especially if you're monitoring a tumor with a good prognosis. You might be doing scans every 3 months or 4 months. So one must avoid unnecessary phases. And the radiologist will help you with something called a dual energy scan, where you need not even do a plain scan because you can subtract the iodine from the scan. And follow-up scans can be limited to the area of interest. You can do other imaging such as an MR or a contrast enhanced USG if you are really worried about the radiation risk. Make sure if you're getting scans from outside that you have DICOM images. DICOM is the digital imaging and communications in medicine. It is an international standard for medical images and related information. And this can be used to work on the workstations or the PACS within your hospital. And all the post-processing that we can do can be done on this. If you get a CD full of JPEG images, they're looking very pretty, but there is nothing that we can do to process these images. So it is very important when you're asking for a CD of the patient to get DICOM images. So how do you get the most from your CT scan? So this is my concluding slide. Please make friends with the radiologist. It is you giving the clinical picture, explaining the precise question, and the expertise of the radiologist that will give the best possible scan. Rule out confounders like I showed you earlier. Plan the contrast and the phases that you need. On the workstation, we need to study the DICOM images. The plates are redundant because that gives you a very, very small percentage. So you can have a workstation which is free on your Windows or your Mac computer, or you use the workstation which is used by the radiologist. Always confirm the identity of the patient and the date of the study, because the patient might come with 5 or 6 different imagings. Luckily, side is not a problem with the CT scan when you see it on a workstation. Traditionally, we are looking from the foot end of the patient. So the left side of the patient is on the right side of the image we are seeing, and vice versa. But it is obviously important that you shouldn't put the plates the wrong way around. And post-processing can be easily done as per requirement. So I'll just end here and leave it to the other distinguished panelists to take you through the specific problems. Thank you for a patient hearing.
Thank you so much, Sudeep. You can stop sharing your thanks. Yeah. I think you need such a brainy guy like Sudeep to explain to you the most basic stuff in such an effortless manner. Thanks so much for that. And next we have a young, dynamic, dashing trauma surgeon from my own institute at AIIMS Rishikesh, who's helped set up this fantastic trauma center we have here. It's probably the first helipad, I think, in the country in a government hospital. And they regularly use that for evacuation of patients from the hills and such like. So to elucidate on the use of CT, I know, Madhur, it's a very short time to tell you to stick to 15 minutes alone. So I'm hoping we get at least some images. So over to you for taking the trauma out of a traumatic CT.
Thank you, sir. Thanks very much. And I'll just begin with my slides. Good evening, everybody. And I'll be talking about computer tomography in trauma, basically chest and abdominal trauma. So what we'll cover in this session, in this time which is allotted to me, are the basic questions which a general surgeon faces and some representative images of different situations. So what does a common surgeon think when he has a patient of trauma in his ED and he thinks about a scan or a CT scan? The first question that comes to his mind, that at what point of time should I get a CT scan done? Then the second question, oh, his chest is injured, the ribs are fractured. Shall I get an abdomen also? Will it increase the radiation dose? Will it be harmful? Shall I extend it to the neck, or what should I do? Then, like Sir said in his last session, that the onus to plan is upon the surgeon. So which type of CT I get? Do I get a contrast enhanced CT in trauma, or do I get a non-contrast CT in trauma? Then there's a question of your fellow radiologist being angry all the time that I'll not take this patient inside until you get me a normal creatinine report. And we all know how fast the turnover of KFT is in our labs. So what to do? Do I need, because trauma, time is of essence. So what do we do? I mean, should I wait for KFT or should I rush the patient? And last but not the least, we shall also be answering the question, okay, fine. this patient has come. It is beyond the capacity of my center. Now I have to refer the patient. So shall I delay his transfer for a CT, which might be useful later on, or shall I just transfer the patient's sat on? So answering these questions one by one. So whenever we get a patient in trauma, we deal him the ATLS way. The ATLS way is comprised of two surveys, which is primary survey and secondary survey. In primary survey, we look for airways, problem in airways, and we stabilize the cervical spine. We do all the maneuvers which are necessary to prevent an airway collapse. Secondly, we see the breathing part, that is a chest part, by look, listen, feel method, and do the procedures necessary before jumping on to the step. The third step, which is circulation, we provide good IV lines, Russian fluids and bloods, and we try to stabilize the vitals of the patient, that is basically the blood pressure and the heart rate. And then comes the neurological disability, the focused neurological examination, which is pupillary size, lateralizing signs, and GCS of the patient. And then we prevent the hypothermia of the patient, and we expose and see. So there are various sections to the primary survey. What the primary survey actually means is that if we go through A, C, D, and E, we will hemodynamically stabilize the patient. And if the patient is not hemodynamically stabilized by taking care of A, B, C, D, he is not going into CT room, he's going into OR. Secondary survey is the complete head-to-toe examination. And the point I want to stress here is that CT in trauma is an adjunct to secondary survey, which translates that CT cannot be done until the primary survey is complete, which means until we achieve hemodynamic stability of the patient. This fact has been stressed all over the world. No wonder in a circle of trauma, we call that CT rooms and elevators are graveyards for trauma patients. So now coming to the question 2, should we get a whole body CT done or a selective CT done? Okay, fine. We have been taught by a very good medical system in India, where we've been told to highly rely on clinical acumen. So should we make use of that, or should we blindly go carelessly ordering the whole body CT? There are questions. There are the few issues which we have to answer while answering this question. First is definitely of the resources. Are you equipped enough? Is the patient paying enough to have a whole body CT, or he cannot afford? Affordability is a major issue here. Then, what is the sensitivity of a whole body CT as compared to the clinical assessment? Whether it's a overshot, whether it's overkill or whole body CT, or whether we should go by our clinical assessment. Is there any role in outcome of whole body CT versus selective CT? And is the radiation dosage really a problem if you go for a whole body CT rather than doing a focused computer tomography? And are there any associated benefits of whole body CT? So first, coming to the issue of sensitivity, talking about the first thing, which was resources, we can't say much because that is neither in the scope of this, I think, session, but rather we as doctors can't do much about it. But yes, addressing the question of sensitivity. So there have been multiple studies which tilt the evidence in favor of whole body CT in cases of trauma. So there's a meta-analysis of 11 studies which showed 32,000 patients, and which gave a simple conclusion that clinical assessment and mechanisms underestimate injury severity by 30%. In trauma, 30% means a lot. Again, there has been a study, again, a systematic review of more than 25,000 patients, in which they found out that trauma patients undergoing whole body CT have better survival than those in selective imaging. What I want to stress upon is that in whole body CT, here in these studies, the injury severity score was much higher than the selective CTs. But even then, they had a better survival. And again, another study of more than 32,000 patients, which tell us that whole body CT is associated with lower overall and 24 hours mortality. So this clearly suggests, and these are just few of the representative studies which I've quoted, but most of the studies suggest that when the patient is of trauma and the question comes into your mind, just the question that comes into mind that whether I should get a whole body or just a focus CT, we should err on the doing side. We should order on the doing side when sensitivity is compared. Again, then there have been studies which have compared whether the whole body CT should be done or there should be a selective strategy. But there are a lot of missed injuries. The patient gets maybe scanned once, twice, or again through the selective strategies. And we have realized that a similar radiation dose at discharges, there are similar radiation dose. There's no significant difference between whole body CT versus selective strategy because of the repeated scannings later on for any other injury which has been missed in the primary injury. Any other benefit? I just want to recollect, I was doing my observership in Japan in Osaka City University Hospital Trauma. And I realized in the morning, a patient came and he went a pan CT for trauma, aneurysm of aorta, which was not traumatic. So patient came for something else, but he got operated for other things. And these incidental findings, if you see, are not less. So there are other benefits also of doing whole body CT. Now coming back to the first question of resources, we can't do much, but if we have to be selective, let us consider the dangerous mechanism of injury. And this has actually a lot of value. If there is a dangerous mechanism injury, even if the patient comes to you walking and talking near ED, but somebody, his co-passenger has died. He tells you that, okay, if I met an accident with my car, my fellow passenger died, but I'm here fine. You know, the studies have suggested that he has some significant injury or the CT was relevant in these cases. If the fall from height is more than 3 feet or 5 stairs, CT should be done. If there's a high-speed motor vehicle collision or a two-wheeler versus a four-wheeler, whatever speed it is indication for a whole body CT. And if there is delayed extrication, that is somebody is stuck in a vehicle for more than 20 minutes, that means for 20 minutes, no resuscitative efforts could be done. The study tilts in favor of whole body CT versus selective CT. So now, what is whole body CT? What do we mean by whole body CT? It is generally it is NC-CT head and cervical spine, that is non-contrast CT of the head and C spine. It is contrast enhanced CT of the torso. It's not isolated chest or abdomen, but of torso, and it follows the phases like Shah sir already discussed. I'll not exert on that more. So what additions could be done? So according to suspected injuries, sometimes you might add a few add-ons to the whole body CT protocol. For example, if you're suspecting penetrating neck trauma or blunt cerebrovascular injury, we might add an angiogram for aortic arch to the vertex. If we are suspecting traumatic renal injury, a renal excretory phase may be added. For bladder injuries, we might request for a CT cystogram. For peripheral vascular injuries, CT angio with reconstruction gives us a very good roadmap for operative procedures later. And then the question which actually the surgical residents are afraid of. They go to the radiologist, no, and not until a normal creatinine report comes. So how much is this valuable in trauma? Because trauma is all about time, is about saving time so that we can manage the patient in the golden hours or the platinum minutes. Yes, the incidence of CT is significant. There is around 5.1% incidence of contrast-induced nephropathy in trauma patients. So should that hinder us from getting a CT without KFT? But then there is another thing that yes, there is a contrast-induced nephropathy, but what is the actual outcome? What happens later on? So this study, which I want to mention, had more than 500 patients, and only 2 times all serum creatinine levels peaked within 48 hours of giving the contrast. But what happened was that all of them usually came back to normal, and this study suggested the clinical course was benign. Moreover, that 5.1% includes people of all the ages. And here, this is a study of the Lancet, which I want to show you, that trauma is the disease of the young. You can see that it peaks at 20 to 24 years of age. And after 65, the incidence is really less. All of you are surgeons, most of them you would be dealing in trauma. You would seldom see an elderly or a very small child. Of course, they are there, but the percentage is very less. So when we consider this fact of age and we pit it against the incidence, it becomes much less than 5.1%, and it becomes much less significant. So the take-home message we can take here in trauma is that if age is less than 65 years, timely CECT trumps KFT. You can go ahead, get a CECT done. More often than not, you'll be out of trouble. So now coming for CT in chest trauma, we'll be just discussing some representative images, and later on, I'll be glad to answer whatever questions put forwards. So why do we get a CT chest in trauma? We usually have an X-ray which tells us a lot about most things about trauma, but yes, if the mechanism of injury directs or if the patient's condition is that we are suspecting something, and our major goal is that whether a procedure is required or not. So what do we look for in CT chest trauma? We look for rib fractures, we look for pulmonary contusions, we look for pulmonary lacerations, hemothorax, and pneumothorax. These are the most common things which we use. So now Shah sir has already explained beautifully about the windows, and as you all know that the windows basically they just matters. There's a ratio between the width and level, which is like the different shades of gray, I must rather say. So various shades of gray are there, and adjusting those shades of gray, we can focus upon the Hounsfield units which we want. So the chest can, what do we want to focus in the chest? If we are looking just for the rib fractures, we can focus upon the Hounsfield units from 500 to 1000, where we can see rib fractures very clearly. In the left picture, you can see the rib fractures, that is the discontinuity in the cortex. When we follow the axial sections and we follow each of one of them separately, you can see that. And then there are the lung parenchyma, like sir said, it's beautifully visible in the range of 500 to 700 HU. So if we focus upon, and these things are already there in the software, they're preset in the software. So we don't have to apply anything or apply any brain, we just have to go for a lung window or a bone window. We can ask the radiologist friend, okay, fine, I want to see the bone window or I want to see the lung window. So in the lung window, we see a better visualization of the parenchyma. Like I mentioned, its most common blunt chest trauma mortality is, yes, it's high. In elderly, 4 times. And with each rib fracture, studies have suggested there's a slightly more than 100 ml loss of blood. But most important than all, it is what I want to stress upon is that a rib fracture is an indicator of underlying injury. You would remember that we used to make a lot of hue and cry about flail chest. But later on, we realized that the flail chest is not the one killing the patients. It's actually underlying pulmonary contusions. And in the ATLS 10th edition, flail chest has been downgraded from life-threatening injuries. So basically, if we see a rib fracture, we have to wonder what is underlying. So the bone, just a bone window will not suffice. We'll have to see for the lung window as well. Here you see that lung windows. What we can see is we can appreciate the parenchyma as well. On the right side, you can see that the rib fracture is also there, but it's not staring us into the eye. It's not staring us into the face. But the lung parenchyma is very, very clear to us. And more clearer are things like pneumothorax. They're jet black. You can see here. And the lung parenchyma and things like contusions and all, which I'll be coming to again. And then this beautiful 3D reconstruction by the software, which is usually done in the MDCTs, which leaves nothing to guess, which I think bears everything, peels off the skin of the body, and we can see the rib fractures very clearly with the eyes. It is important in cases where we are planning to fix the ribs, because now there is the studies which are coming, new studies are coming, they're suggesting that there's the patient gets early to the work. And if the rib fractures are deforming, if they're pressing, if a rib has gone inside the parenchyma, injuring, it more or less makes sense to fix the rib than not to. And there is less pain also. So when you're planning any of the rib fractures, a 3D reconstruction gives a very good roadmap. And what are pulmonary contusions? So when we see a picture like this, where there is a focal, non-segmental parenchymal opacification, which is usually peripheral. And I mean, if to cherry on the cake, if there's a rib fracture nearby, adjacent to it, so you can very well say that it's a pulmonary contusion. These actually evolve after 24 hours, and they stay for at least 1 week, and the patient usually gets worse before he gets better. So we have to follow up them. Usually with X-rays, it suffices. Then there is pulmonary laceration. Pulmonary lacerations are almost always associated with pulmonary contusions. They're nothing but, like you can see, they're like pneumatoceles or pneumatohemoceles, like which are air-filled cavities along with a pulmonary contusion, sometimes with air fluid level. So these are pulmonary lacerations, and they typically look like this on an axial CT scan. Then there is hemothorax, which can be identified very well in bone window. And here you can see that there's a big hemothorax on the right side and a minimal hemothorax on the left side. It is usually collection on the dependent part of the body. And then pneumothorax, as I mentioned, it's very well seen in the lung window, where you can see very dark, almost black air spaces, and you can see the lung in between, which is compressed. So this is how pneumothorax looks like. So abdominal CT in trauma, the trend these days is to get a torso CT done, not abdomen or chest again. So it is basically a part of CCT torso and majorly guided by mechanism of injury or a fast positive status. If the patient is fast positive and taken to for imaging, for CT imaging, and you find that there is hemoperitoneum, but with no solid organ or hollow viscous injury, it is usually followed by diagnostic laparoscopy, because then the cause is the mesenteric bleed, which is usually usually not commonly seen in the CT scans. So what solid organs we can discuss are, we can discuss spleen, liver, pancreas, and kidneys, and hollow viscous bowel and bladder are there. So this is the ASK grading. I'll be comparing a representative image with the ASK grading of that's American Association of Society of Trauma grading, along with the
Madhur, we're running short of time. Huh? Just
yes. So what I want to tell about in spleen is, if you see on the right side, I'll not be discussing about the ASK grading, but you see that yes, there's an enhancing parenchyma and there's non-enhancing parenchyma. Let me tell you frankly, before this, we used to think that spleen was the commonest injury, but it's not. It's liver, because livers are more forgiving than spleen. That's why, and the CT scan, like Sir said, has come in only 90s and more in 2000s. Before that, people only spleen was unforgiving, so people used to end up in OR, and we used to find most damaged spleen than liver. Liver also, there are ARC gradings. You can see on the left side, and here we can see. So in spleen, we have to intervene. We have to go for at least splenic artery angioembolization or splenectomy if it is around grade 3 or more. But in liver, we can be conservative, even grade 4 or grade 5. If the patient is hemodynamically stable, if there's no active contrast extravasation, we can go for a conservative management. And if it's grade 4-5 patient hemodynamically stable, it's always safe to have angioembolization done if you're in a setup which has one. In pancreatic trauma, I just want to tell one thing, that is, when there is injury which traverses more than half of the parenchyma, it is considered as grade 3. And that is the indication of any intervention. Less than grade 3, we don't usually intervene in trauma. Renal trauma also, the ASK grading is there. Here I just want to tell take-home messages. If it's greater than 4, it means it has crossed the pelvic ileal system. And that is where there is a gray zone that we should intervene or not. But now the studies are suggesting that for most injuries, for almost majority of the injuries, we can do without intervening, and conservative approaches considered in renal trauma. Bladder rupture is very good. You can see on the left side, there can be intraperitoneal bladder rupture where contrast will be all around the bowel, and there can be an extraperitoneal bladder rupture, which is contained in the extraperitoneal cavity. We don't have to do anything for 2 weeks. We keep a Foley and the patient is fine after that. So to end, if I have 4 points to tell, I will just tell that no CT should be done after until the patient is hemodynamically stable. Whenever the doubt comes into your mind, it's better to overdo rather than to underdo that order whole body CT. If there are no extremes of age, forget about KFT. Time will have the better results. And if we have to transfer the patient to a higher center, we should not delay the transfer for the CT. Thank you.
Thank you, Madhur, for a very exhaustive. I know it's very difficult to summarize in that, and I think we'll need another session. I'm sure Santosh is going to catch all the trauma guys for another session on trauma itself. You're used to whole day long ATLS sessions. So with that, we move on to the next gem in our necklace, Dr. Parthasarathi Ghosh from the Diamond Harbour Government Medical College in West Bengal. And he's going to be covering CT in acute abdomen.
Please unmute yourself, Dr. Parthasarathi. Your slides are visible. Please unmute and start speaking. Dr. Parthasarathi, you're muted. Dr. Parthasarathi, we can't hear you. You're still muted. I think he's not able to.
Can you hear us?
Should we call him? Should we call him?
Dr. Partha, can you hear us?
I'll just make the call.
You're muted, Partha, you're muted.
I am calling him, but he is not answering, means that he's not able to hear anything. I'll just.
Can you hear me?
Yeah,
now
you-
we can. Now we can finally. You have to speak a little louder, Partha. Yeah.
Okay.
Sir, you please start speaking because
Yes,
time
sir.
is.
Sir, good evening, everybody. Now, CT in acute abdomen. Now, what is the role of CT actually? The true role of a CT is where it can really make a critical difference in the clinical puzzles. Not infrequently, the surgeon encounters a patient in the emergency with acute abdominal condition that doesn't fit any of the clinical patterns. And obviously, in many of the occasions, the patient is sick, but the diagnosis remains elusive. So, but why a surgeon? Why a surgeon should read a CT? But because of the simple reason, different physicians look into an acute abdomen in different manner, even in the image. The radiologists, they have very surprised and they see too much and they don't understand actually the clinical significance. And the ear physician, they are in an intention to dump the patient, so they don't try to understand and they don't see much. So this leaves us with ourselves that we are actually have the capacity to better understand the natural history of the disease process, and we should be the finest interpreters of the abdominal imaging because we can corroborate it with the clinical scenario. The road to the operating room not always should pass through the CT scanner, but an indicated CT should not be avoided for decision of any surgeon. The supremacy of CT scan in today's world is well known because it can pick up pre-gas, fluid, masses, tissue planes, inflammatory changes, opacities, blood vessels, organ perfusion. Most important, this is very important that it can pick up organ perfusion, but it should not. But the tilt towards doing CT scan in many of the cases should be justified because we should not allow delay to the treatment of the patient. Now, as already discussed, in the setting of emergency surgery, IV contrast is almost mandatory, but oral diluted gastrografin or rectally given gastrografin is not always required, but it can be considered, rectal enema should be considered in the setting of acute diverticulitis, obstructive colonic lesions, or sometimes colonic trauma. But gynecological, if we suspect a gynecological pathology, a vaginal tampon sometimes help. But exception is one. If we want to see a ureteric stone or renal calculi, no contrast is actually required. These are some common abdominal conditions. There are so many conditions. These are some common abdominal conditions, but I will not discuss the last few. I will discuss only this condition. Now, in case of appendicitis, we get many of the cases where the patient comes with a right iliac fossa pain, and one of the biggest challenges when we detect or when we try to detect appendicitis in imaging is to find out the appendix. But once confidently identified, the assessing its normality is probably a relatively straightforward. Now, when we are looking for appendicitis, so two questions comes into our mind after detection of the appendix, whether it is an appendicitis or not, and whether there are other complications or not. Now, to look for that, whether the appendix is sick or not, we have to go for the first for the appendial signs. Two most important is dilatation over 6 millimeter and its wall enhancement. Now, periappendiceal signs now for detecting of complication, the fat stranding, phlegmon formation, abscess or extraluminant glass or fluid inside the pelvis. Now, if we want to identify that the base of the appendix is a fixed, almost fixed. So if we see this image, this is the telescoping indicates the ileocecal valve, and in between the ileocecal valve and the tip of the cecum, the base of the appendix is always present. This is fixed. The tip may vary, position of the tip may vary, but the base is always fixed. So this is the basic thing to identify an appendix. Here in this this coronal section, we can see some a structure in the right iliac fossa, and we also try to see the appendix in the axial in both the cuts. But if we enlarge that image, we can see that in this picture that this is the appendix. It's a blind tubular structure, but the teeth is more than 6 millimeter. Now, if in the same patient again, we can see some changes in the periappendiceal area, like fat stranding, which is greater than the normal fat, and as well as there are some reactive lymph nodes here, which indicates the diagnosis of appendicitis. Now, in this axial section, we can see that this is the appendix, and the appendix is going towards an abscess actually. So it's an appendicular abscess where there is wall enhancement with fluid content, and as well as we can see an appendicular. Now, this is another picture of appendicitis where we can see the phlegmon which is formed around the appendix. Now, this is a 24 years girl, but presented with a pain in the right iliac fossa and the suprapubic area. The ultrasound was a bit confusing. So the CT shows that yes, the appendix here is not dilated, and we can see something in the right ovary along with some peritoneal collection and some peritoneal changes, even the thickening of the peritoneum here. Now, there are some common pitfalls in acute appendicitis where there is, number one is the enlargement without secondary signs. Sometimes there is non-visualization, and sometimes right lower quadrant inflammation with normal or non-visualized appendix. Now, if the appendix is enlarged with no secondary signs, it is actually the size of the appendix, or which is the most important determinant factor. And if you see it is less than 6 millimeter, it is 0. If it's more than 9, it's most of 50% of the cases. Even in absence of secondary signs, the appendix is pathological. If the appendix is not identified and there are no secondary signs, the chance of appendicitis is very less. But if the appendix is normal with signs of right lower quadrant inflammation, then appendicitis is possible in 1/4 of the cases. But you have to think of the other options even. Now, if we shift to the left iliac fossa, the CT serves some important. The first thing that comes into our mind is the diverticulitis. So it confirms the diagnosis. Sometimes CT is very important investigation. Diagnosis of diverticulitis. It evaluates the severity and extent of the disease and helps us planning the management in case of diverticulitis. And we sometimes see some differentiating things that mimics diverticulitis. Now, CT findings in case of uncomplicated diverticulitis is colonic wall thickening, and very importantly, the pericolic or the fat stranding or inflammatory changes. Now, identifiable inflamed diverticulum is sometimes or rarely seen. Now, CT findings of complicated diverticulitis are same like abscess formation, extraluminal air bubbles or pockets, and sometimes very important is the fistula formation. Now, in this in this coronal image, we can see that the sigmoid colon is thickened along with formation of a phlegmon in this area, and so this indicates that it is a case of diverticulitis. Now, these are two different images of two different patients. Here we can see the thickening of the sigmoid colon along with fat spreading. But in this case, we can see the air-filled diverticula, but there are no pericolonic changes. So this is actually Hinche type 1A by classification, which can be managed conservatively. Another case where these are from the same patient, where we can see that there are some fat stranding here, but if we go into the pelvis, we can appreciate that there is an pelvic abscess. So it's a Hinche type 2 where there is an abscess. Now, in this case, we can see that there is some extraluminal gas and fluid collection outside the colon. And here we can see the thick wall, and there are some extraluminal air. And so this is a free communication, and this is Hinche type 3. But in this case, but Hinche type 3 and type 4, they are very difficult to differentiate in most of the CT scan. But here is one scan where we can see the fecal material outside the lumen, as well as we can see some, free air, and as well as the perforation of the sigmoid colon. So this is one where the fecal material is coming out of the colon, and this is Hinche type 4. Now, in some cases, we can present if the colon is normal, the diagnosis of diverticulitis is excluded, and here the appendices epilepsy that is inflamed in this particular image. Now, the next one is bowel perforation. So whenever we are dealing with it, the first question that appears in our mind, is there any perforation? So we need to know about the signs of perforation, and most importantly, to identify subfield perforation feature this in an X-ray. Now, and next is what is the site of perforation, and if possible, the cause of perforation. Now, the signs of perforation, there must be number one is extraluminal air. Extraluminal contrast, if it is at all present, it gives a very good clue, and discontinuity of the bowel wall. And indirect, of course, the abscess of the signs of peritonitis or abscess formation, phlegmon, or foreign body lymphoid outside the lumen. Now, in case of peritoneum, pneumoperitoneum, we always have to look in the wide window so that we can see the ears in the anterior abdominal wall. In the CT, you have to look for the peritoneum, pneumoperitoneum in the anterior abdominal wall, in between the liver and the cage, and sometimes within the peritoneal folds. So this is the difference. If we see it in the bony window, it is well appreciated, very well appreciated, which may be missed sometimes in the soft tissue window. But where is the site of perforation? We have to look for the discontinuity of the bowel, air collection at the site of the injury, extravasation of the contrast, wall thickening, fat spreading in the adjacent mesentery, fluid collection, and localized. So we have to look where the signs are more, then the chance of detection of site of perforation is very high. Here in this case, we can see that there is pneumoperitoneum. There are some fluid collection inside the peritoneum, and this is a very aged elderly person, nearly about the age of 90. And here we can see this triangular air pocket indicates that points towards the perforation of the gastric wall, and this patient was on corticosteroids. So this clearly defines the site and the etiology of the perforation. Here in this schematic, there is contrast inside the stomach, and we can see the thickening of the duodenal wall. At the same time, we can see the diluted contrast in between in the perihepatic area, as well as we can see the free gas. Even we can notice some amount of contrast in the pelvis. So the diagnosis is very clear. This is a young gentleman presented after a blunt abdominal trauma, where we can see some extraluminal gas in the proximal small bowel, as well as we can appreciate a gap in the continuity of the jejunal wall. So again, the etiology and the site of perforation is well appreciated. Acute cholecystitis in this are mostly picked up by the ultrasound, but there the CT features are cholecystic inflammatory changes, GB wall thickening, pericholecystitis fluid, GB wall enhancement, and presence of intraluminal gas, which is better seen in CT. Now, gallstones may not be seen in CT. They may be hypoattenuating or hyperattenuating as per the surrounding bite. Now, here we can see that there are some pericholecystitic fluid and wall thickening, and which indicates, and there are also some fat stranding here, so it indicates that there is acute cholecystitis. Now, in this image, we can see in the non-antidependent area, there is collection of gas, which is sometimes rarely seen in, sometimes seen in ultrasound, where with the change of the position, this white particles, which are actually air bubbles, moves against the gravity and gives the appearance of a Sampen sign or effervescent gallbladder sign. Now, this is a beautiful picture of emphysematous cholecystitis, where we can see here around the gallbladder, and some, again, if you follow that there is air within the liver parenchyma as well, and some free air inside the peritoneum. Again, this is the formation of the abscess. We can see the stone at the neck, but the gallbladder is collapsed here. We can see in this section actually better. So a collapsed gallbladder along with abscess. So it's a case of gallbladder perforation. Now, sometimes ruptured liver abscess we can see that it is rarely visible in case in a non-contrast CT, in arterial phase and in portal venous phase. And if we follow this coronal plane, we can see that there is some discontinuity as well as some fat stranding or inflammatory changes, which indicate that this liver abscess, which is pyogenic, the cluster sign is there, and it has leaked into the peritoneal cavity. Now, the mesenteric ischemia, though we encountered mesenteric ischemia very rarely, but if it presents in the emergency and if we cannot pick it up, it is devastating. Now, to identify mesenteric ischemia, we have to evaluate the bowel as well. We have to evaluate the vessels. For evaluation of the bowel, we have to look for the enhancement of the bowel wall, thickening of the bowel wall, bowel dilatation, mesenteric edema, and pneumatosis as well, or sometimes intraperitoneal wall. And in case of ischemia, we have to look for whether there is arterial occlusion or venous occlusion. Now, in this SMA occlusion, we can see that there is some pneumatosis. At the same time, a large part of this small bowel is actually ischemic or gangrenous. But you can see that enhancement is there in the proximal bowel. Now, if we go to the look for the SMA here, the SMA is blocked here, and after it produces the jejunal branch and the middle colic artery. And you can see that the proximal jejunum is survived, but as the right colic branch is gone, we can see that there are some problems in the cecum. So this is how SMA of occlusion can be well picked up in CT scan. So we don't perform angiography nowadays. Now, SMV occlusion, here we can see that there are some thrombus inside the SMV, but the difference is that in this here, the bowels walls are thin, paper thin actually. They are not thick. But in case of SMV, as the venous return is not there, we can see the ischemic bowel wall is very thick. So this is the difference in the findings or signs of bowel, small bowel, in case of mesenteric occlusion. Now, a renal or ureteric colic. This is one situation I already have mentioned, that we don't need to give contrast, where we don't need to give intravenous contrast. And one thing is very important: we always have to remember that what is the course of the ureter, so that we can pick up the ureteric calculus. So in this case, I will go through 3 slides, where the stone is stuck at 3 positions, which indicates the anatomical force of the ureter. So here in the left kidney, we can see that there are some obstructive changes, hydronephrotic changes, and we can see there is a stone almost at the lower pole, near the lower pole of the kidney, and in the coronal image, we can see that it is stuck here. Now, in the next CT, again, there are some hydronephrotic changes on the right side, and we can see that there is a radiopaque shadow just in front of the transverse processus, and we can see the radiopaque shadow in the course of the ureteric line. And in the coronal section, again, we can see it well that it is stuck in the mid ureter. And again, we can see another ureteric stone stuck in the vesicoureteric junction here, and it can be well seen in the coronal section. Now, there is only problem if you cannot differentiate it with a flebolit. So, if you can, in case of flebolit, in case of ureteric calculi, actually we get a soft tissue rim around it if the stone is not too large. Otherwise, but in case of flebolit, that soft tissue rim is actually missing. So, the take-home message: the key word in the effective use of abdominal CT is not only the sensitivity or the specificity that we generally discuss. It is actually the selectivity of the patients. Rather than indicating a need for exploration, CT is more useful in deciding when not to operate, avoiding unnecessary exploratory laparotomies. And also, a normal CT can exclude surgical abdominal condition, allowing the early discharge of the patient without the need for admission or observation. Thank you. Thank you very, very much.
Thank you, Dr. Partha, for actually anticipating some of the questions which are there in the Facebook chat box and answering. Many of them are very practical pearls from you. Thanks so much. And next we have Dr. Venu Madhav from the prestigious Nizam's Institute of Medical Sciences, and he's going to be speaking on deobstructing the obstructions, so the obstructive jaundice as well as the bowel obstruction, intestinal obstruction. Over to you, Dr. Venu. We can see your slides, yeah.
Good evening, everybody. Now I'll start my topic, CT scan for surgeons, and I'll be dealing with biliary and bowel obstruction. So I'll be dealing with more of small bowel obstruction and some large bowel obstruction, and briefly about biliary obstruction. So what are we interested in small bowel obstruction? First is there obstruction or it's simply ileus? And if the obstruction is present, we need to know where is the location, what is the cause of obstruction? And it's also important to know whether it's a complete or incomplete obstruction, that because it has a management implications. Whether it's a closed loop obstruction or evidence of strangulation, that signifies the urgency in dealing the case. And can it be managed conservatively? CT gives a very useful information. So the major criteria for obstruction on CT for small bowel is more than 2.5 centimeters and colon is not dilated. And second most important point is a transition point is present. So this is a CT scan of the serial axial sections of CT scan done of a patient with pain, abdominal vomiting. You can see the distended dilated bowel loops. The small bowel loops are dilated, and you have to serially follow from up down. Small bowel, usually the philosophy is to follow from up and down, and so in this case, you can see that there's a, as you follow serially, you can see there's something intraluminally in the terminalium, and there's some collapsed small bowel loops. And if you follow further, you can see the transition point. So there's something in occluding, and if you take the coronal deformated images, you can see something radiopen density, and beyond that there's a block. So we can identify the site of block by serially following the CT on serial axial curves. The small bowel should be ideally followed from above down. So not all patients require CT with IV and oral contrast. This patient had renal failure, so we did a plain CT, and on the serial imaging, we see that the small bowel is dilated, and you can see there's a large small bowel is hugely dilated, and This is called small bowel feces sign, which indicates an advanced obstruction. And if you follow the colon should be followed from below. Here the rectum is filled with fecal matter but not dilated. If you serially follow the rectum from below, you can see the descending colon. And you can see the cecum also filled with fecal matter. But the most glaring is the small bowel feces sign, which indicates advanced obstruction. And this patient had a high renal creatinine, high renal parameters, so we did with a plain CT, which gave very useful information. So always the images have to be viewed in serial axial curves, coronal and sagittal. In this image of CT, which showing an obstetric internal hernia, herniation. So some cuts are very useful in identifying the location of the obstruction. Quickly, we'll go to some images of small bowel obstruction. This is a proximal obstruction, this is a duodenum, and this is a hugely distended jejunum. And see, you can see the narrowing and some thickening. When the small bowel is wall is more than 4 mm, it's very significant thickening, and more than 1 cm thickening is a very significant thickening. And there's an apple you can see there's actually a malignancy of the proximal jejunum with hugely dilated jejunum. So CT scan can be very useful in identifying these malignancies. This is one more case, young patient with recurrent pain abdomen. We can see the small bowel loops are hugely dilated, and we can again see there's inspirated fecal matter like this is small bowel feces, which says a imminent obstruction, and we can see the dilated loops, and this is some thickening in the distal non-dilated loops as well. So this is this is one more image which shows prominent vasa recta in the mesentery, and even the mesentery, there's a lot of fat content in between the bowel loops. So this case is a case of Crohn's disease, and if you do a correct CT enterography, we can even identify the skip lesions as well and other lesions as well. So this is a case of Crohn's disease. Again, CT can give you surprise, like in a case of small bowel obstruction, the wall is grossly thickened, small bowel is grossly thickened, and this case of gist of small bowel. So coming to incomplete obstruction, this patient had some X-ray showing some air fluid levels with gas in the colon. So this patient was managed conservatively and his obstruction got relieved. But in recurrent attacks, we did a CT enteroclysis which showed intraluminal growth. So if patient got relieved also, if you do a CT enteroclysis sort of thing, we can identify the growth. So this is again a small bowel obstruction. The glaring thing here is there is a twisting of the mesentery, and what we call as a whirling of the mesenteric vessels in the mid abdomen. This signifies a closed loop obstruction and volvulus. This patient, you can see clearly there's a twist around the mesentery. So this is a very important sign which signifies a closed loop obstruction and had to be operated urgently. Rarely we can encounter a case like this where it's case of portal cavernoma, a lot of vessels, SMV thrombosis, and this patient had stricture, usually dilated jejunum with jejunal stricture. So if you delay intervention, these patients may go with pneumatosis in the intestinal wall and perforation also. This is a closed loop band causing closed loop obstruction causing perforation. All this can be beautifully elucidated by a CT scan. So what are the CT scan signs of strangulated bowel obstruction? One is a gasless abdomen or a fluid-filled abdomen, target or halo sign, mural pneumatosis, gas in the portal vein or SMV, and the Will sign. These are signs of strangulated small bowel obstruction. CT scan of abdomen and should be considered in all patients with small bowel obstruction because it can provide incremental information over plain films in differentiating grade, severity, and etiology of small bowel obstructions that may lead to change of management. And there are other techniques to identify small bowels, like this is CT enterography, which gives multiplanar imaging, and with oral contrast, CT enteroclysis, there rights to be passed in the nasogenital tube and then passed. So you can see serially follow the small bowel loops. All the DJ flexion is to the right side of the SMV, which is a complete non-rotation. So we can see the small bowel loops are to the left side and right side on the coronal view. This C. So small bowel loops are into the left side and to the right side where the large bowels. And the recent techniques like CT colonoscopy can identify the intraluminal mass as well. See, this is a growth within the lumen, which can be identified by CT colonoscopy. This is by recent 3D reformatted images, which gives the CT colonoscopy image showing the polyp also. Not only that, CT scan gives a very favorable information about the difficulty of surgery. This is a recurrent CS stomach with a lot of fat planes with the anterior abdominal wall, and it will signify a very difficult surgery. This is an interesting case of left paraduodenal hernia where the bowel has herniated in the left pararenal space, and this is due to non-attachment of the descending mesocolon, and anteriorly the inferior mesenteric vein and left descending vessels will be there. So this is case of left paraduodenal hernia. So after the pelvic surgery, these bowel loops are seen and loss of fat planes will be a very difficult surgery. So CT scan will give an indication of the difficulty in surgery also. So this is a case of clumped bowel loops and omentum is grossly thickened, and this is case of sclerosing peritonitis, where you can see the omentum is thickly encasing the proximal bowel loops. So, and you can also see that posteriorly there is a lot of less stranding. So the approach to this should be from posterior. If you try to separate the bowel loops from anteriorly, it will lead to injury. But whereas if you try to mobilize and do additional lysis from posteriorly, you will be able to do a better job. So CT scan will guide us very usefully in not only in diagnosis but also in management. Coming briefly to large bowel obstruction. So this is a large bowel obstruction. So as I said, large bowel obstruction, better to follow the bowel from below up. So this is a descending colon, sigmoid colon obstruction. So if you follow, this is the area where it is showing thickening. This is a site. So grossly thickened descending colon causing proximal obstruction and closed loop obstruction. We can also see cases of intussusception where the ileum is intussuscepted into the cecum. We can see the mesenteric vessels, fat, and a target sign which is seen in intussusception. In case of sigmoid bolus, is better diagnosed by X-ray abdominally, and in CT can give additional information like the twisting of the mesenteric vessels and rule out other diagnoses. There are cases of pseudo obstruction where is a very important differential diagnosis in large bowel obstruction, especially in elderly and neurological disorders, where the colon will be dilated till the distal end, and there is no tapering. CT scan is better illustrated, and even if you give a rectal contrast, we can better identify these pseudo obstructions. So, summarizing the role of CT in intestinal obstruction, if there is no alarming symptoms in a stable patient, in these patients, CT can add high value in some patients. It can help inadvertent non-operative management of patients with bowel ischemia or strangulation. It can diagnose non-additional causes. It can identify the level and location of obstruction and suggest a closed loop obstruction or a mass or a potential internal hernia. I will also be briefly dealing with CT biliary obstruction. Briefly, what is biliary obstruction present? What is the level of obstruction and what is the cause of obstruction? So this is a case of the serial axial CT scans, the plain film. We can see hypodensities in the liver. So we have to serially follow this, probably bile duct, but we have to comment on the contrast phase. So we have to serially follow, and we can see this is a distended, gross distended gallbladder, and this is the bile duct. Coming to the contrast phase, this is the lower end of the bile duct. Coming to the contrast phase, see here normally the intrahepatic biliary radicals are 2 to 3 mm. If it is dilated more than that, it's hugely dilated, and it should never be more than the size of the portal vein radicals. So if it is dilated more than the portal vein radicals, that indicates its obstruction, and you can follow it serially. The obstruction, the bile duct is distended, is a head of the pancreas. Yeah, the distension is going, the bile duct is distended all the way down. There is one more case of chronic pancreatitis with head mass. With you can see a lot of calcification and head mass, and this is causing the biliary obstruction. We'll go to the contrast phase. So this is the contrast phase. This is a head mass, hugely dilated head mass with head of the pancreas with a lot of calcification in the pancreas, which is causing the biliary obstruction. So CT scan can give us an information about the cause of obstructive jaundice. This is again one more CT. It's showing grossly dilated bile ducts and the portal wheel. The gallbladder is hugely distended. There's thickening of the gallbladder wall, which may suggest a malignancy, which is causing obstruction of the biliary system. And there is also splenomegaly. And this patient, okay, sorry. So this is a hilar obstruction. So block is at the level of the hilum, the gallbladder is collapsed. So CT scan, by serially following the CT scan, both coronal and axial cuts, we can have a clue of the site of obstruction. And once we have already, as illustrated by prior speakers, the arterial phase, portal vein phase, and equilibrium phase will give a very good clue of what are the relation with the vessels and what are we dealing with, what type of mass we are dealing with. And also we can get by MIT images, we can get a cholangiogram sort of picture, but there's another technique called CT cholangiography, where the contrast agents excreted through bile are given, and that will give an excellent quality of cholangiogram as well in these patients. And they are routinely using that for CT in evaluation of donors in some centers. So CT can be evaluated is for post-cholecystectomy pain. You can see a retained gallbladder in the partial cholecystectomy causing pain. Coldocolithiasis CT scan, most of the stones are radiolucent. So in this case, as you see, this is a radiolucent stone stuck in the distal CVD. Some radiopaque stones can be seen. You can see a crescent sign, usually on the dependent portion, and the dilated CVD, and some pericoldocal inflammation. So CT scan plays an important role in the evaluation of biliary obstruction, especially malignant obstruction, and in evaluating the cause of biliary obstruction, especially non-stone disease. Thank you.
Thank you so much, Venu. And with that, we move on to the next part of the session, which is Dr. Sanjeev Haribhakti from the Kaizen Hospital, Ahmedabad. Sanjeev is he's one of the coolest surgeons I know. He's apart from being spiritually inclined, he runs courses on Bhagavad Gita. He's very innovative. He's described he's made retractors. He's written textbooks on surgical gastro. So he's eminently suited to give his talk on post-op abdominal complications.
Thanks, Puneet, for those kind words. I'll go to the presentation. So are you able to see the slides?
Yeah, we can see, yeah. Just maximize slideshow.
Yeah, fine. Okay, so my job is to talk about post-operative CT scan. So in the post-operative period, CT scan is a very, very important part of investigation, because many of the post-operative unsettled abdomens on the day 3rd or the day 4th, when the patient is not settling, this is the time that we start thinking whether this is an ileus, is it an obstruction, or is it an anastomotic leak? And this is the time that CT gives you the answer to many of your questions. And that's why we have a very low threshold of doing a CT scan in the post-operative period, because it actually pinpoints the problem and helps us to manage these patients, whether to conserve them, whether to put in a percutaneous drain, or whether to sometimes re-explore them. So evaluation of the post-operative CT scan is challenging, because in the post-operative period, the anatomy is altered, difficulties in planning protocols, there are artifacts, and the patient compliance issues. So the post-operative complications are quite well known to all of us. Early complications are bleeding, ileus, and obstruction, how to differentiate them. Talking of anastomotic leak, abscess, and peritonitis. Late complications like adhesions, hernias, anastomotic strictures, and recurrence of tumors or IBDs, inflammatory conditions. Now, contrast agents already has been elucidated by Dr. Sudeep. Positive contrast, negative contrast, when do we use which ones? Just suffice to say here that in an acute abdomen, and even a non-contrast CT will tell us about the perforations, because the presence of extraluminal air will help us. But in a postoperative abdomen, that does not help us. And that's why in postoperative abdomen, there is no role of a non-contrast CT. We always need to use a contrast CT. But for particular situations, you can use particular agents. If, for example, you want to check the anastomosis around the esophagus or the stomach, you may just use the oral contrast. You want to check a low anterior resection anastomosis, you could use a rectal contrast CT. But most of the times you use it with the IV contrast so that we can look for collections also. IV contrast is a non-iodinated ionic contrast. There is a risk of nephrotoxicity. We have already discussed this. But if the creatinine is raised, then one needs to calculate the eGFR for the patient based on the age, creatinine, sex, and ethnicity. And based on eGFR, one can decide whether to hydrate the patient and take up, whether to give N-acetylcysteine, Mucomix, and to take these patients up, or should not avoid doing a CT scan if eGFR is less than 30. So the phases of CT scan also has been covered earlier in the presentations, the non-contrast, the arterial, early, late, the portovenous phase, the venous phase, and the delayed phase. Hounsfield units has also been discussed by Puneet, how air has a minus 1000, it is black, and bones is a positive, it is white. Dilemmas that we see on a CT is how to differentiate an anastomotic leak and a complex anastomosis, differentiating fluid from abscesses, differentiating ileus from obstruction, unlabeled bowel and a collection, and sometimes surgical materials which are left behind, and differentiating them from a collection. So how to differentiate a free fluid from an abscess? Free fluid is the early postoperative period. It is more in the dependent portions, pouch of Douglas, and there is no gas in the dependent aspect, whereas abscesses occur about 3 or 4 days later. They are more near the anastomotic sites. They have a thick enhancing margins or walls, and there is gas within this fluid. So this is the free fluid. It is ascites. It's more in the depending portions here in both the sides. Whereas this is an abscess where there is you can see a wall around the abscess. There is some air pockets, some around those areas. This is a very well localized collection with the air pockets inside. Now, sometimes topical hemostatic agents are used after, say here, after cholecystectomy. How to differentiate this from a collection? There is no peripheral enhancement here. It is tightly packed linear array of bubbles which are located centrally, and there are no air fluid levels. This consists of more geometric shapes, and there is no change in bubble size on serial imaging. And this shows that this is a topical hemostat. Whereas gauzy epibomas or foreign bodies retained after surgeries can show very characteristic picture. You can see here there is a heterogeneous mass with a peripheral enhancing wall, multiple air pockets in the central part, and there are some radio-opaque markers also seen. These are classical findings of a gauze, a foreign body or a mop left behind in the abdomen. Differentiating paralytic ileus and obstruction may not be very difficult on a CT. Air in the rectum and sigmoid is absent in a small bowel or a large bowel obstruction, whereas it is present in ileus. And generally, we can differentiate. I'll show you the images, the pictures. Here you can see that in paralytic ileus, not just the small bowel, but even the large bowel is dilated right till the end to the rectum. So there will be, dilatation all throughout the bowel. There is no air fluid levels are not significant, not the step pattern classically that we see. In obstruction, we need to use a positive oral contrast is preferred. We should avoid giving mannitol because it's more like osmotic. It kind of exudes a lot of fluid into the lumen of the bowel. And the major advantage of doing a CT scan in a postoperative or a subacute obstruction in the postoperative period is that sometimes because of the osmotic effect of the oral contrast, the obstruction does open up and the patient is relieved of the obstruction. So that is one of the therapeutic roles of using an oral contrast in the postoperative period to get rid of the obstruction. Now, this is a patient who had an obstruction of the mid-ileal level due to adhesions. Here you can see that there is a lot of dilated ileal loops here. But then as we go down, we will see that there are some collapsed loops here. There may be sometimes a transition, sometimes there cannot be any, there may not be transition. Here you can see that there is a dilated loop and then there is a gross transition. These are all the collapsed distal ileal loops reaching up to the cecum. So this was adhesion after total colectomy and ileostomy. Bleeding, CT angio can be used for bleeding, but it should be at least a 0.1 to 0.5 ml per minute. It can help us to localize the site of the bleed. It can be useful for a roadmap for angioembolization, and one should not give any positive oral contrast if you are suspecting bleeding. It should be a CT angio protocol where the bleed will give us contrast blush with a pooling of contrast on delayed phases. So this was one of our recent patients who had a contrast blush from the gastroduodenal artery and the hepatic artery following a necrosectomy. There was a bleeding from the arterial pseudoaneurysm, which was bleeding here, and that was later on embolized. So these are very important roadmaps to embolization. Similarly, this was one of our recent patients who had a trauma Whipple. He had a liver tear and a pancreatic transaction with duodenal transaction. Postoperatively on the 5th day, he had a major bleed, and this was a side of bleed. There's a blush you can see here coming up into this blush, which is coming from one of the vessels branches of the supramesenteric artery. But on exploration, we found that it was the right branch of the middle colic artery, which was bleeding and which was sutured. You can see here that this is the kind of blush that we will see on a CT angio, and this will tell us the site of the bleeding in these patients. Hematomas, collections with enhancement or non-contrast with the Hounsfield units of about 60 to 90s will suggest that this is an hematoma, there is an intra-abdominal bleed. Anastomotic leaks are very important, and for this we need to use oral contrast or the rectal contrast depending on the site of the anastomosis, and the leak of contrast will be evident. The protocol of CT is important. We should use a non-contrast CT scan for comparison of contrast leak and positive contrast, and sometimes you can even avoid the IV contrast. But IV contrast will help us to evaluate the collections and the bowel wall as well. So the timing, amount, and the route of contrast agent depends on the site of anastomosis. For the proximal, you use the oral contrast. For the colorectal, use the rectal contrast. Now here, this was a patient in whom this is a leak from a patient had a gastric pull-up for malignancy, and this patient leaked from the mediastinum. Now we can see here that's a gastric conduit, and that is the area from where there is a leak from the gastric conduit into the into the right side of the chest, thoracic cavity. It was a very large leak. We waited for nearly 4 months, but this did not work out and this did not close. Patient was having persistent sepsis. So we went ahead and last month we did a decortication. We excluded this conduit, did a cervical esophagostomy and a feeding jejunostomy and excluded this conduit, and the patient went home yesterday. This was a patient who had ileotransverse anastomosis after a right hemicolectomy. This patient had a very low albumin, actually had a proximal stoma, but then this patient had a sepsis and a leak from the anastomosis from the right, from the ileotransverse anastomosis. Here you can see there is a leakage of the contrast and going into the collection. And then this patient, because this patient had a stoma, a proximal ileostomy was managed conservatively and the patient improved and recovered. Now this is a contrast extravasation from the duodenum. The patient who had a gastric pull-up for a pharyngoesophageal stricture. Actually, this patient had a corrosive stricture of the pharynx. We tried to take up the colon, but then it became ischemic, and that's why we took up the stomach as a conduit in the posterior mediastinum. And this patient developed a post-operative duodenal leak where there was a contrast leaking, and this healed on a conservative management. CT fistulogram can also be used provided the fistula has become matured. You can use a CT sinogram or a fistulogram to evaluate these patients and look, but this should be done before we give any oral contrast or intravenous contrast. First, we should push the contrast from the sinus or the fistula and try to see its origin. So this is how we can use this was a sinus tract from which the sinus was inserted, dye was inserted. We need to see whether there is a bowel anastomosis or a bowel continuity. Where is the tract going? And then we can give an IV contrast. So the take-home message in the post-operative setting, CT scan is an invariably important investigation for us. Adequate history of the patient must be communicated to the radiologist. That is very important. The anatomy of the postoperative situation should be also communicated with the radiologist. And what is the clinical suspicion, what we want to look, what we are actually looking for. Sometimes we need to tell them that they don't need to push too much of contrast when there is recent anastomosis. We need to be very careful about how much contrast we need to give these patients. It should not be done like a normal CT scan, and other investigation modalities also should be communicated with the radiologist. But more important than that, I think it's our own assessment of the situation, planning of the CD protocol and sitting together with the radiologist on the console certainly definitely helps, to pinpoint the problem and to properly manage these patients. Thank you.
Thank you, Sanjeev, for a very lucid presentation on one of the most vexing issues where CT is used most frequently, probably. And finally, we end up with Dr. Rajesh Gupta, professor at PGI Chandigarh, with one of the largest experiences in the country with acute pancreatitis. He's going to talk on CT in acute pancreatitis.
Thank you, Puneet, and the scientific committee of the ASI for this opportunity. So I think first I'll start with the basic definitions and then correlate these with the CT findings. It's important for us to understand that acute pancreatitis is a common cause of hospitalization, but fortunately 3/4 of these patients have self-limiting course and imaging is rarely necessary for these patients. However, for the remaining 1/4 of the patients who have prolonged hospitalization, high morbidity and mortality, there is a need for repeat imaging. The revision of the original Atlanta classification of 92, which happened in 2012, inserted another grade of severity, which was moderately severe pancreatitis, in addition to mild and severe pancreatitis. It also divided the clinical phase of the pancreatitis into the first week, which was the initial phase of the pancreatitis, and beyond first week, which was the late phase of the pancreatitis. And then there were two morphological types with the peripancreatic collections, and also differentiated further organ failure into transient organ failure, which was organ failure lasting less than 48 hours, and a persistent organ failure lasting more than 48 hours. So this is when I was talking about the morphological two subtypes of acute pancreatitis. These are actually interstitial edematous pancreatitis and necrotizing pancreatitis. So if there is no necrosis in pancreas, then it is interstitial edematous pancreatitis. And if there is a collection which is there within the first 4 weeks, it will be labeled as acute peripancreatic fluid collection. However, the same after 4 weeks, when it gets encapsulated and localized and is homogeneous with predominantly liquid component and no solid component, is pseudocyst. The counterpart of this in necrotic pancreatitis is acute necrotizing collection and a walled off necrosis. And all these collections can be either sterile or infected. So we know that now we have to understand that necrosis is the major issue in pancreatitis, and necrosis can happen with parenchyma or with peripancreatic necrosis, or it can be a combined necrosis. So coming to pancreatic necrosis is actually a non-viable pancreatic tissue which develops early in the course of the illness. It is established by 48 to 72 hours and essentially takes 3 types, which we discussed earlier. Pure parenchymal necrosis is actually less than 5%, while pure extrapancreatic necrosis is less than 20%. Here the pancreas is actually normal, and the most common is the combined necrosis, which is the 75 to 80% of the population. So what is the role of CT in acute pancreatitis? Do we require it for diagnosis? As per the revised Atlanta classification, if there is a typical abdominal pain, which means pain which is starting in the epigastrium, which is continuous crescendo type of pain, radiating to the back with amylase or lipase level more than 3 times, there is actually no need of imaging for establishing the diagnosis. Also, one has to understand that the severity in the early clinical phase is determined by the presence of systemic inflammatory response syndrome and organ failure rather than by any imaging finding, as there is no correlation between the morphological changes and the clinical course. However, in early phase, if the symptoms are atypical or the enzyme levels are raised less than 3 times, then obviously there is a need for imaging to make a diagnosis of acute pancreatitis. Also, if we encounter first attack of acute pancreatitis in a patient who is elderly or maybe beyond 65 to 70 years of age, this is his first attack and there is no other etiology of acute pancreatitis like gallstones or alcohol intake, then neoplasm has to be suspected and CTs warranted in this early phase also. Also, if the condition of the patient deteriorates, there is an indication. The indications of CT scan in late phase are actually different. CT scan helps in prognosticating the course of the illness and also in planning management. We'll discuss these issues little later. So as we have understood now that CT identifies necrosis after 72 hours. So there is no point doing CT scan earlier than that in acute pancreatitis, as it will not pick up necrosis. So it should be performed after 3 or 5 days preferably. But more importantly, the CT scan should include pancreatic parenchymal phase, which is the phase of maximal enhancement of the parenchyma. And in that phase, if there is an area, as you see here in the right frame, there is no enhancement, the rest of the pancreas is enhancing, then you can label this as acute pancreatitis, which is missed if the CT scan is done early when the whole of the pancreas is showing enhancement, but subsequently developed necrosis. So as I said, it is important to differentiate between the two morphological types, acute interstitial or edematous pancreatitis and necrotizing pancreatitis. The difference would be that in edematous or interstitial pancreatitis, the pancreas would be enhancing very beautifully. As you see, the star is around the parenchyma, but there is stranding of the surrounding peripancreatic tissues. And if it occurs before early weeks, as I said, it is called as acute peripancreatic fluid collection. And the same when it gets encapsulated will be called as pseudocyst. In contrast, here on the right frame, on the upper side, you find that the stars show necrosis of the parenchyma, which is also extending into the peripancreatic fat. And in the phase which is less than 4 weeks of the onset, it will be called as acute necrotic collection. And the same when it shows localization and becomes walled off will be called as walled off necrosis. So I think it's important for us to understand what is the meaning of this walled or walled off necrosis or localization. If we find a wall which is thick and enhancing, as you see here, compare this with a wall here. This also shows localization, but this is thin wall. So this is neither we see good enhancement here. So we cannot call this cavity as localized or walled off necrosis. This wall, which is covering more than 80% of the cavity and thick and enhancing, will make it a walled off necrosis. And if this walling or the localization or this wall is seen in less than 80%, then you cannot call it a wall of necrosis. So this is an example where only parenchyma is involved and the rest of the peripancreatic tissue is seen clearly. As I said, this is seen in only 5% of the patients of total acute pancreatitis. Then here one finds pancreas is enhancing well, but there is stranding, which is becoming walled off. And this is again a peripancreatic necrosis without involvement of the parenchyma. The importance of this finding is that this kind of pancreatitis has a course which is better than the parenchymal necrosis, but obviously worse than the edematous or the interstitial pancreatitis. So then this is the most common variety where the stars showed necrosis of the pancreas while the arrows show peripancreatic tissue, and necrosis or stranding, which is walled off after 4 weeks. Another role of CT scan is in prognosticating the course or prognosticating the disease and telling us about the course of the severity. Balthazar severity score came up first in 1985, and then the necrotic elements were added, and we finally had CT severity index of Balthazar, which actually is a progression of the inflammation of the pancreas from diffuse enlargement to peripancreatic inflammation to single fluid collection to more than one collection, and the scoring is from 1 to 3, 4. This was the original Balthazar grades, but then they added necrosis, and they said that if the necrosis was less than 30%, the score 2 was given, and then another grade was 30 to 50 and more than 50%, and the total accumulated score was 10. Mortel modified this, and he actually tried to make it simpler by combining B and C of Balthazar, when it said whether there was pancreatic gland enlargement or peripancreatic standing, the score will be given 2. And if there is any collection, it did not differentiate between single or 2 collections, and any collection, the score was given as 4. It removed the 30 to 50% category and gave 2 score to less than 30% and 4 score to more than 30%. But important, the Mortel gave importance to extrapancreatic complication like pleural effusion, where another score of 2 was added. So I'll give some examples of these scores and how there is difference in the 2 scores. As we see, there is enlargement of the pancreas, and the peripancreatic fat is seen clearly all around. So this is Balthazar grade C or CTSI2, and in modified CTSI also the score is 2. However, when we come to this slide, we find that there is single peripancreatic collection. There is no necrosis of the pancreas. So CTSI will give a score of 3 to this. When we look at the modified or the Mortel's CTSI, it will give any collection in the peripancreatic tissue a score of 4. But since this patient also has pleural effusion, so the score for modified CTSI becomes 6. Now we compare this scoring with the clinical course, and we found that the patient actually had persistent organ failure and severe acute pancreatitis, though this patient survived. Here is another example of difference between the 2 scores, where there is necrosis which is involving more than 50%, and there are more than 1 collection, which gives CTSI of 10. But if we look at modified CTSI, it is only 8 because there is no extra pancreatic collection. All the collections are in the peripancreatic region. There is no discordance when you have extra pancreatic collection and the necrosis is more than 50%, and there is more than 1 extra pancreatic collection. So both CTSI and modified CTSI make it 10. Here we have additional finding, which I thought I will discuss here only, a gas in the pancreatic collection. So if we have gas in this pancreatic collection, then it would mean actually presence of infection or there is bowel fistulization. But provided that patient did not have any fine needle aspiration cytology done, or there was no pigtail catheter placed in this collection. In this patient, since there is a pigtail catheter placed in this collection, presence of the air has actually no value. Another role, as I said, of the CT scan is in telling us whether the collections can be tackled by radiological means or by endoscopic means, and which modality would be useful, ultrasound or EUS or CT guidance. What would be the site of puncture? That also CT can help us find out. And then what is the follow-up of these collections? And for any surgical intervention or for any intervention, a CT scan would act as a roadmap and is must. This is a patient which has predominantly peripancreatic collection in the early phase, but then develops necrosis. And this is actually tracking towards the retroperitoneum or the paracolic area. And what is required is an ultrasound guided placement of percutaneous catheter in this collection. Compared to this patient where there is a collection in the center of the pancreas, however, there is overlying bowel gas and the patient is obese. So ultrasound would not be useful, and the approach also has to be from the anterior abdominal wall. So CT has told us about which modality to be used and the site of the puncture. Similarly, in a patient like this also helps in monitoring the collection, where though a pigtail catheter has been placed right in the collection, but it has not helped, and this route was actually used subsequently for surgical video-assisted retroperitoneal drainage. In addition, CT scan also tells us about the bowel complication in a patient who developed acute pain on postoperative day 28, and CT showed here a diagnosis of duodenal fistulization was made. Similarly, we found that CT scan in a patient who had blood from the drains showed aneurysm from the gastroduodenal artery, which was embolized successfully. So I would conclude by saying that for CT scan, which is performed to evaluate to evaluate acute pancreatitis, pancreatic phase is must. Timing of CT scan is important to detect necrosis and also to tell us about the extent of necrosis. CT severity assessment tells us about the prognostication of this patient. It tells us how the patient would probably behave and gives us a roadmap. CT would be required for any intervention, and repeat CT is in order when we are monitoring the course of these patients. Thank you. Thank you.
Thanks so much, Rajesh, for some very lucid messages. Although we targeted the younger postgraduates, I think a lot of important messages for the expert surgeons as well. There's one area where I find excess CTs being done. I think you gave extremely lucid messages about when to do it. And it's a coincidence that just before, half an hour before we started this session, I got a phone call curiously from Chandigarh itself, where a biliary pancreatitis had at least 2 unindicated CTs by your criteria. And I think you're absolutely right. We need those, and also the subtle points of where ultrasound versus CT. So I think I thank you all for a fantastic session. And I think you can all switch your videos back on, and we have I think Santosh will have to run on because there are some lovely questions which are there. So I'll crack on first. I think Sudeep, are you there? So, I mean, you could take this. It's not technically a thing, but I thought you might know more about this. Is online reporting legally acceptable?
Now, that's a very interesting question, but I don't know how to answer that for India, but I know that a lot of CTs in the US are actually reported from Bangalore. So yeah, I don't know whether there is any legality. I'm not a medical legal expert, but I don't see why not.
Yeah. I think there's a series of things, particularly in the pandemic era, that the government has actually brought out for making the online completely compliant with, legally compliant with all the other things, so that actually protects us, the doctors, more. So like you said, Arjun Kalyanpurkar in Bangalore set up this, radiological outsourcing for the US, and a lot of other centers followed suit. But even for our own country, I think it's a very important model. Maybe you should write up for NMJ or something like that on how we should actually use this for. There's a nice article in one of the journals where we could use it for rural areas. So you have the facilities available. This is an Australian New Zealand Journal Surgery, where the rural outposts, they have all the facilities, but they don't have somebody to report. So we need those. Here it's a little more tricky because we need the equipment there. So I mean, it can be made legally compliant. So I think that does answer that bit. With imaging of various types at every place, what is the current place of, if in doubt, open and see? I think that's a fantastic question. And it, many of my students are always, I tease them with this HBT, LC, CT scan bit. So I think the true thing is that the clinical, we should not become a slave of CT. The CT should be a help aid. It's a surgical aid for us. It's a stethoscope. We should not let it become a master. So the final decision has to be clinical. So any thoughts? I think I can see Rajesh furiously shaking his head. So would you want
No,
to say?
I can't agree more than, that. I mean, we see that we are actually making these images more important and downgrading the importance of our own clinical acumen. And that's a very heavy price that we are paying. And we are not making good diagnosis based on CT scans alone. So I would agree that if there is a clear-cut scenario where there is an indication to go in, doing an unnecessary CT scan and delaying the procedure actually is detrimental.
Yeah, I mean, the classical example I give is that if you see a patient in obstruction who's completely resolved, he's past flatus, but the CT scan is showing you the typical features of narrowing and all that. I think Venu might like to answer that question, but you're not going to operate on that patient merely because of the CT. So we have to operate on the patient, not on the shadow. When Madhur was giving his talk, there was a nice comment in the Facebook chat box about, when he was saying that the primary survey and all that, and somebody said man scan is important rather than just the CAT scan. So I think that answers it. One point is that where we are in doubt, I think it's an invaluable tool. When we are in doubt, it's a sort of a legal rest, if you like, but we should not use it indiscriminately as thinking that it's going to protect us. Finally, it has to be a surgical call. With that, move on to the next one. CT versus clinical examination, is it equivalent to machine versus man? I think it's partly the same. Sudeep, you want to comment?
CT is ultimately an adjunct, and as technology increases, we have more and more adjuncts. And I think a very good point made by all the speakers is that CT gives support to your conservative treatment. So I think that's a very, very important role. Your patient is stable. You want to conserve liver tears, you want to conserve splenic tears, you want to conserve intestinal obstruction. Then CT is very, very good for that. And obviously, if one needs to get on with it, one needs to get on with it. So I think that's a very good message.
Yeah, I think that's a very important point you made about the conservation bit. Also, the patient who's the old elderly comorbid, where you don't want to jump in. That's another one where you want to conserve the patient himself. So I think that's a very, very, very valid point that you made about conservation.
Just one point, Puneet, if I'm allowed.
Yeah.
Yeah, in context to pancreatitis, where one would need probably a series of scans subsequently. So in the initial phase, when there is no indication, we should not unnecessarily subject these patients to CT scan, as it will not make any difference to the management.
Absolutely. In fact, every guidelines, apart from the Japanese guidelines, does not recommend CT upfront as the first investigation of choice. It's exactly the points that you said. If you have typical pain, typical amylase, and no other features of peritonism, you don't need a CT. It's only when you're in doubt. I think it's only the Japanese guidelines, because they're sort of probably more defensive medicine, which says that you do CT upfront. So absolutely right. So this is for Madhur. When delayed issues are many in trauma, what is the ideal time frame for imaging?
Beg your pardon, sir. Delayed issues are many.
Are many in trauma. When delayed issues are many in trauma, what is the ideal time frame for imaging?
I guess the person wants to ask that when should it be done, right? When there are many delayed issues.
Yeah.
So, what is if we are suspecting trauma, sir? Unlike other places, for example, I want to just impress upon the fact that CT or not to CT. There are places in trauma where CT is not as effective. For example, in diagnosing the cervical spine trauma, we have very good criteria like Nexus criteria or Canadian C-spine rule, which are very clinical criteria, very simple criteria. And their sensitivity is as good as 99%, which is equivalent to CT scan. So in those cases, CTs are not advised or they should not be ordered, but it has been seen in trauma. Evidence is there that in primary, after secondary survey, if we suspect it, we better get it done in the secondary survey itself rather than waiting for, get it done for different parts in different stages.
Right. Thank you. There's another one for you. Chest X-ray has no hemopneumothorax, but CT picks it up. If the oxygen saturation is maintained, is it needed to have an ICD? Technically, this is outside our ambit because it's on the ICD, but since you're there, I think you might, and our aim is
so that's a very good question and a very pertinent one. So when we don't see pneumothorax, which is many a times missed on X-rays, but is seen on CT, it is called an occult pneumothorax. So in normal conditions where we have facilities for monitoring, we don't need to put in a chest tube. But if this patient goes into, for example, for any other reason, goes into a positive pressure ventilation or has to be transported via air ambulance where there is a possibility of change in pressures, a prophylactic ICD should be put, sir. Otherwise, no need of an ICD if you can monitor the patient.
Thank you. Then we have for Partha, in acute appendicitis, when is CT asked for? Any objective parameters available?
No, it's absolutely not required every time. If there is any doubt that you are not dealing with a case of acute appendicitis or something where for that period you go for any conservative or a minimum, you go for a radio guided drainage for that time only. In those cases, we should ask for a CT. Otherwise,
I think that's true. One indication I've found is very useful is if it's an older patient with appendicitis, especially the elderly patient. We've discovered a lot of pseudomyxoma or the mucinous tumors of the appendix where a mucocele is picked up, and we can actually do a laparotomy rather than just a laparoscopic appendicectomy. So that's one of the things I've found which is useful. But like you said, Rajesh also said, where we want to, Sudeep said, when we want to conserve, I think we would like to do, or there's a diagnosis in doubt, we'd like to do it. A similar question, when is CT indicated in acute cholecystitis? If clinical diagnosis is supported by ultrasound. I think we have to understand for gallstones, ultrasound is the best. For acute cholecystitis, HIDA is actually the most diagnostic, but in that scenario, we generally tend to use acalculous cholecystitis. We tend to particularly use CT if the ultrasound is not showing any calculi, and you want to make sure that you're not missing out anything else. Anything else you would like to add, Dr. Partha?
no, sir. That is adequate. Actually, I have already mentioned that ultrasound is adequate in almost all the occasions. And again, in case of acalculous cholecystitis, especially where we go for a pigtail drainage or any abscess that we don't want to handle surgically at that point of time.
Yeah, I mean, that ultrasound versus CT, I think Rajesh gave a beautiful, that the photograph itself is very, very, a single picture says it all. When it's a peripheral thing, you can actually put even an ultrasound guided drain. So that's exactly the place where it's useful. And the post-op setting, I think, is one where CT scores over ultrasound hugely. Then for Venu, we have a question. If there are multiple fluid levels in plain X-ray abdomen in a clinical setting of intestinal obstructions, which are the patients who need CT?
So again, when we are suspecting if it's a clear-cut complete obstruction clinically and there is no colonic gas and patients have signs of peritonitis, then straight away we can go for surgery. It's only when the clinical signs are borderline and then fluid levels are there. For better evaluation, CT scan is a very useful tool because you can pick up many things, and if creatinine is normal and everything is normal, we can go for a CT scan with contrast, or even plain CT can give accurate localization of the site and cause of obstruction in these cases. But if there are imminent signs of obstruction, imminent sign of closed loop obstruction on CT, then strangulation or peritonitis, straight away we can go for surgery.
Yeah, I think that's spot on. And I'm glad you actually stressed the point about gas in the colon, because the question didn't say that. But I think that's a very, very crucial thing. Whether you're looking at the plain X-ray or the CT, you're looking at a distended small bowel and absence of, so it's not, you're not missing out ileus or something like that. It's the absence of gas in the colon, which is crucial. Since it's targeted at the young PGs, I think they tend to miss that. I always notice in the rounds, they'll always show me all the air fluid levels. So sometimes we might have cases where air fluid levels are, routinely present in a patient who's admitted in the wards, recumbent, not moving around. But it's the whole constellation of symptoms and that finding of no gas in the colon, which is actually more important. There's one of my ex-colleagues from Gujarat, I think he's worked with Sanjeev also at some stage, who, to cost cut, what he used to say is that I give my patients gastrographin. And in the COVID times, we actually used it for one of the senior most Naga sadhus here, who was just in charge of the Kumbh Mela. So he said that I give them the gastrograph and I tell them if you pass stools, it's fine. Otherwise, you'll need a CT scan. So he saves the cost of the CT scan itself. I thought that was a useful nugget to share in the resource constrained areas where, you could try it in a remote area and quickly transfer for a CT, to the adjacent metropolis. So that's as you.
It can also make a subacute obstruction acute and then expedite the treatment.
So, I mean, gastrographin, and funnily at that time I realized they've stopped using gastrographin now. I personally have found gastrographin extremely useful. And I always said, when people say, why do CTs? I believe the diagnosis is clinical and CT should only be used where you want to conserve, as Sudeep said. But I found that when you use gastrographin and it clears up, it actually usually is quite helpful. So why not use only gastrographin is an extremely valid and cheap, argument. I'm not sure it causes it acute because it's water soluble, so it does get absorbed completely. The fear I notice a lot of my fellow surgeons, colleagues have had is that it aspirates. I think that fear is really important for the very young, the pediatric ages, where there's pulmonary edema, which can pull in the fluid. The hygroscopic nature of gastrographin will pull in the fluid. So I'm not sure it really, have you had any instance where it's actually caused acute? Okay. So yeah, but I mean, barium has been known to do that. So that's why barium is almost never recommended. Barium can clump. I've operated on several patients in my postgraduate time with, clumped barium obstruction, which is obstructing, and it's a plastic. And if there's a perforation along with that, it can be quite a plastic peritonitis as well. Right. So I'm glad it's not used now for that at all. So then we have CT scores are revised very often. Is it because of better CT? I guess it's directed at Rajesh. That's the timing of the thing. Is it because of better CT, or is it better interpretation or better wisdom?
I think it actually probably make the management more comprehensive, because if you look at, I'm talking in context to acute pancreatitis. If you look at the initial Balthazar score, the initial Balthazar scores were only looking at the pancreas and the peripancreatic elections, subsequent, which was in 1985. So
that's because it was done very early. That is the time when CT was done in the first 48 hours.
So then they realized that the pancreatic phase CT scan could pick up necrosis. So then they added the score of necrosis. But then we realized that it was not only these peripancreatic elections, but there are extra pancreatic elections also. So then they were also factored in and the scores were modified so this is the evolution of the understanding of the disease, which led to the modification of the scores, I would say.
Thank you. I think that's, Santosh, that's the end of, I'll just ask some of the things which I thought of, which are not, Sudeep, the concept of two things is, a lot of kids think that the slice is like the anatomy, soft parts, where it's a slice. But I just wanted you to explain the slice concept, that it's like a slice of toast, that it's the entire thing.
So it is like a Lego block.
Exactly.
So it's a three-dimensional reconstruction, which can be rotated, reconstructed. So you can have oblique, you can have transverse, you can have vertical. And the technology is just absolutely fantastic. So,
yeah. So I mean, the point I wanted to make was on the partial voluming artifact. If the slice is thick versus the slice is small, whether you pick up that sensitivity will be altered. Do you want to highlight?
To be honest, Puneet, with the modern machines, we used to see that a lot when we started CT scans. In early 2000, you would get all that. The pixelation and the edge enhancement and the overlaps. But with the modern multi-slice machine, I think we are more or less gone with this concept of overlap. You're having a 3 millimeter voxel and extremely sharp imaging.
Right. Another point was about the contrast you mentioned about dialysis. I think one of the points that many of these radiologists say is that although we all recommend dialysis, the contrast is a contact poison. So the moment it's hit, so the damage is done. So the dialysis is only going to prevent further damage. I just want to make that point.
Absolutely.
But a lot of kids say, why don't we, this patient of renal failure, let's give it and then dialyze it. So it's not like that. It's a contact poison. It is to limit damage.
But the CT is usually done because hopefully it's going to change your clinical decision. So it's not taken lightly. and dialysis immediately will minimize the damage. Absolutely.
Right. So any last minute messages each of you want to give, which has not been covered so far? Madhur.
So there's just a question, very interesting one in the chat, that what about CT in penetrating trauma? Well, that is very site dependent. For example, if the penetrating trauma is in abdomen, the breach in peritoneum warrants a diagnostic lab at least. But then there's a new concept of CT tractogram, where you put the dye in the wound itself and see whether it's going into the abdomen to check whether there's actual breach or not. Then there are cases where even the proximity would warrant a CT. For example, say there's a penetrating trauma near a vascular, near a major vessel. So though even their distal pulsations are palpable, but to rule out pseudonism, a CT would be necessary. Then there is the check whether there's actual breach or not. Then there are cases where even the proximity warrant neck exploration has gone. Now we get a CT done, and if it's fine, then there's no need to explore the neck even if there's a breach in platysma.
Yeah, I think very valid points. That tractogram is something I always thought we should do, like Venu's talked about the fistulogram. So I think that's a very useful nugget added. Sudeep, any last minute?
I think you just need to make friends with your radiologist and sit with him, and he will explain so much about the technology to you, and that will just help you make your utilization much better.
Yeah, Partha, anything?
I just want to mention once again, sir, that it only should be done in justified situation. That is the main problem actually we are observing.
Overuse. No, I completely agree. I think just to re-emphasize that, you might do a CT, not pick up something, and you're legally in court, everybody can see that. So if you think you're legally protecting yourself, you might be getting deeper into shit. So I think it's important that we realize that there could be a flip side to it as well. Venu, any last minute nuggets?
Yes. Well, we should correlate our post-operative findings with always the CT and get back to CT and read ourselves, so that day by day we'll improve our CT imaging facility. So that's a very important point, because we can predict some important things while surgery, also difficulty of surgery. Everything can be predicted, because once we go back and see, we can learn a lot of things from the CT scan. That's my message.
So not just have a friendship, but maintain that friendship with the radiologist as well. Sanjeev, anything, any last minute?
I think I often tell my fellows that, CT room or our console is the place that we learn the most. And most of my surgical planning for liver, for pancreas, and all the other, most of the cancers and it happens actually on the console and sitting with the radiologist. I think sitting with them gives us a better perspective, because we are not really the experts on this, and they have a different perspective. So when both the surgical and the radiological perspective merges, I think that's when that discussion brings out the best out of the two, and that's a learning time for us.
Absolutely. I think spot on, Sanjeev. When I started my surgical career right after MS, I joined neurosurgery, and the neurosurgeon used to say, very dramatically, I'm tearing this radiologist report. I'm so glad all the eminent surgeons are, coming up with that. You keep learning day by, Sudeep is one of the most erudite, and if he says that and you say it, I think it's a very important message that we are continuously learning there, and we learn, all the time. Rajesh, any last minute pearls?
I would say that, we need to understand that when we are dealing with acute pancreatitis, large majority, 3/4 of them probably would have a self-limiting clinical course and would not require any imaging. So that must be kept in mind when we are handling these patients and ordering investigations.
Extremely important message. Santosh, anything from you or Dr. Siddesh or?
I'll pour, if you're done with. Thank you very much, Dr. Puneet and the team, for the excellent exposition of, the understanding. I think I would agree and re-emphasize that all images that are interpreted needs a buttering by the clinician. Otherwise, it goes haywire. We need to put our clinical judgment ahead in relation to the CT or whatever imaging. And it's also a good idea that the clinician is capable of reading the CT, understanding it every day. Otherwise, what will happen is you just look at the report, and the report will be, not related to the patient in that clinicity, because there could not be two different entities, clinician on one side and radiologist on the other side, turning head each away from each other. I would like Dr. Siddesh to come in and make some comments as the president. Dr. Siddesh.
Thank you, Santosh. I think I should just congratulate each one of the faculty who have participated today. And Dr. Puneet, you have done a wonderful job coordinating with it. The messages you conveyed looked so subtle, but they were so penetrative. So the language which you used makes them really very, very impressive. So I am just really moved by the way you have taken up this task and allocated the topics to the respective experts. And I would congratulate again all of them. Sudeep, I don't know how you could have been more elaborative. His depth of knowledge on the minute of things, which I never knew about certain things like how to go on the grayscale and all. He has really done it, his depth of knowledge. And not only that, why we need to know as a surgeon through that depth, it will help you to interpret yourself these images much better and make better use of these images. So thank you very much. And at the same time, each one of you in your own field, which has been allocated, you have done a wonderful job covering it very well. And certain things which I never anticipated have come out. That is the most loving thing about it. As a president, I would appreciate that you have all expressed views that how best we can avoid doing unnecessary CT. That is a very important message. We never expected that this will be conveyed in this platform, and it is so beautifully well conveyed. And not only that, another important message what has been conveyed, which I love it, is CT is not just there to guide you and make a diagnosis, but help you to conserve whenever is possible. So that is the most value-added contribution CT can do to your patients, especially critically ill patients, including malignancies. So I think today we have not only gone to the stage of making decisions on whether to go ahead with resections or not, type of resections, radicality, borderline resectability, all these terms, we have come across only because of the advances and better understanding and the relationship between the clinician and the radiologist. So the best way to progress and to refine our knowledge and make best use of this modality is to understand it better. And the best way to do that is start understanding very early. So we need to take our postgraduates to the radiology department at the end of each rounds, what I used to do. So 3 days, definitely our rounds used to end up in radiology department and with the pathologist. So that is the best way to interact and learn, so that even our radiologists will start becoming better and we also will start becoming better. So I think those are my comments. I think we can go on talking, but I just take this opportunity again to congratulate the whole team. So each one of you have been exemplary and very good. Dr. Rajesh, I think you will remember we met in Ahmedabad recently, and that was a good interaction. And Sudeep, I could just barely brush through you. I was in a hurry to catch the flight, so I couldn't speak to you in Pune. So Sanjay, I know we are not met long because of the COVID. Hopefully we'll catch up again soon. So rest of you have done extremely well. Thank you very much for joining. Good night.
Thank you.
Thank you, Dr. Sanjay, for quick comments, if there is any. Dr. Sanjay.
Thank you, Santosh sir, President Dr. Siddesh, officers of the ASI, the esteemed faculty and the dear viewers. It was an excellent program with very elaborate and very clear take-home messages for everyone on a very important imaging modality, which can help the surgeon to pinpoint a diagnosis which otherwise would have been really difficult. The beauty of today's program, there was a lot for everybody, from the young postgraduates to the champions. So that is what I think President has already told. I would just like to say a word of caution, especially to young postgraduates who are in a hurry to be in a false sense of security with a normal or a near normal initial imaging report. Because when I get a call in emergency, sir, we have got the CT done and it is normal. So this is something which they should refrain from. And remember, if you have ordered a CT, the patient must be having some indication, and if there is a normal report, you must watch carefully, and if required, a rescan can be helpful. So with all that, I would like to thank everybody and say good night, and back to Santosh, sir.
Thank you. Dr. Bauer will propose the formal vote of thanks. Dr. Bauer. Bauer, for the vote of thanks, please.
Thank you, Santosh sir. Respected President ASI, Secretary Dr. Barute, and incoming President ASI, Sanjay Jain sir. And first of all, thanks to today's moderator, Dr. Puneet sir, for the excellent presentation on the CECT for the surgeons, for the beginners also, as well as the practicing surgeons also. The CECT is important for making diagnosing as well as carrying out the treatment plan accordingly. So we will achieve a proper outcome. So for that, I congratulate Puneet Dhar sir along with the Galaxy of panelist team who gave their best to the different topics in a very comprehensive way. And also thanks to the Facebook viewers from nationally as well as abroad, who will chip with us in the whole programs and making the success of these programs. And now over to Santosh sir. Thank you all. Good night.
Thank you very much, all the panelists, particularly the moderator and all the panelists. And thank you all the viewers on the Facebook page. Stay safe till we meet next week for a similar program at ASI time, 9 to 11 p.m. next Wednesday. Good night to all. Thank you very much.
Good night, Santosh. Thanks.
Good night, everybody.
Good night.
Thank you.
Good night. Bye, Puneet.